Thank you very much, Hashan, for the very unusual but very interesting patient, and it gives us think about this kind of patients when we meet inflammatory patients with inflammatory arthritis. So we'll go to the next talk of the day. It will be done by Dr. Methsala Gunawardena, consultant rheumatologist at District General Hospital, Trincomalee. And she is going to talk on psychosocial aspects of rheumatic disease. Methsala.
Thank you, sir. Thank you, the College of Specialists in Rheumatology and Rehabilitation, for giving me this opportunity. So today's topic, you all know the psychosocial aspects of rheumatic disease. So it's not a new topic. The rheumatism, as William Haberden Sr. did centuries back, who was after whose name the distal interphalangeal joint deformity in osteoarthritis was named, said that it's a common name for many aches and pains which have yet no particular appellation, name or title, though into very different causes. So I think although we have some sophisticated names in this century, still this statement is valid today, more so than ever. So I will go through some literature after the introduction, and according to the following topics, and finally there will be a question for you all to answer. And don't worry, it will be from the common sense, not from the lecture or the talk, basically. Psychosocial aspect in rheumatology influence many factors such as disease process, patient compliance with treatment and follow-up, doctor-patient relationship, and the disability. Thus, it should be acknowledged by every rheumatologist. So it's a bidirectional association with the disease and the psychosocial factors, including behavioral, psychological, and social factors. It's a bit complex, so going through research, I found that they have categorized into four main domains. because it's a vast area and an area which is not very known to us. So the first domain is the role of behavioral and psychosocial factors in the onset and disease course. Second domain is psychosocial and behavioral consequences of the rheumatologic condition. Third domain is the influence of these factors on patients' perception and the correlation with their rheumatological conditions and development of psychosocial treatment strategies. So first of all, the literature review will be on the first two topics. The first one is the role of behavioral and psychosocial factors for the onset and course of the disease. So there was this review article which nicely summarized a lot of articles regarding depression and the risk of rheumatoid arthritis. And they have found that there was a strong depression as a strong risk factor for rheumatoid arthritis. Not the review article, but they have found several articles favoring the risk factor, depression as a risk factor. Not only as a risk factor, depression is the second most common comorbidity among rheumatoid arthritis patients, even though it's very unrecognized factor. Second to the osteoporosis. So in Western world, osteoporosis is the number one, and second is depression. And it is found to be a risk factor for rheumatoid arthritis as well. Not only depression, the mood disorders and depression both. And the widespread pain, the psychosocial factors were well known for onset of chronic widespread pain by this article. And for the disease flares, they have found that most of the disease flares were associated with the psychological factors, and there were some environmental factors as well, but psychological factors were associated with disease flares, so it is well known. And psychosocial and behavioral consequences of the rheumatic disease, on the other hand, like in psoriatic arthritis, it occurs sleep disturbances, fatigue, and depression. Due to the psoriatic arthritis, as concluded in this study, the prevalence of sleep disturbances, fatigue, anxiety, and depression was frequently reported by psoriatic arthritis patients. And this was not particularly true regarding skin involvement, but particularly true with pain and musculoskeletal involvement. And they have found that musculoskeletal involvement was playing an important role causing sleep disturbances, fatigue, whereas fatigue in psoriatic arthritis patient is strongly associated with anxiety and depression. So, how the psychosocial factors influence patients' perception and coping with the rheumatological conditions is very complex, and it needs understanding of pathophysiology. We have to first find out the factors that affect the disease and illness process, such as behavioral, such as avoidance of physical exercise. As you all know, most of our patients come up with this question whether to go ahead with physical exercise, and the cognitive factors such as pessimistic thoughts, fear of activity, emotional, depression and anxiety, contextual, the availability of emotional, financial supports, and the limitations in the environment. So they affect either directly or indirectly. Directly, directly, pain and fatigue can be related. Pain you all know, is a well-known thing. And fatigue, the subjective sensation of tiredness or exhaustion, which is not relieved by resting. It can be either physical, cognitive, or emotional. They affect the pain and the fatigue level, and indirectly affect the treatment, willingness, and motivation to engage in activity, and likelihood of seeing the doctor in an event of exacerbation. That is very important in our patients with chronic rheumatological conditions. So there are two models to explain how psychosocial factors influence the cognition and this perception points. This is the common sense model, which shows the four domains of psychosocial factors: psychological, physiological, social, and contextual factors affecting the symptoms, well-being, and functioning. Whereas the rheumatic disease causes also affecting that. And the important thing about this model is there's a timeline. And all these are rheumatological conditions are chronic and they evolve over time. So these factors change. So this is not a linear one. This is a progressive related to time. It says these things change. So this is more practical. Whereas this biopsychosocial model is a linear one, which only shows the association of biological, psychological, and social factors interacting with each other. This is not very well recognized in research because of its linear relationship with these factors, which is not very practical in our setting. The cognitive and cognitive factors affect how patient perception about the disease. So the disease varies with the illness. So disease is the pathological process, whereas illness, there's a component of perception. And same goes with impairment and disability, and nociception and pain. The nociceptive stimuli does not always correlate with the pain. Pain may be more because of the cognitive and perception factors. So we have to understand this when we are dealing with patients with especially chronic pain like syndromes. The fact that rheumatic diseases are chronic conditions is important because the interplay of these physical, psychosocial, and behavioral factors, contextual factors, will evolve over time and should not be considered as static. So if we consider them as static, we will fail to identify these factors and act accordingly. And there is a strong pathophysiological basis for this as well. Because inflammatory cytokines are known to provoke the neuroendocrine system, stress system. They signal the brain and change individual perception on their health by reducing psychological, social, and physical functional so-called sickness behavior. So it's not only in your head, there's a strong pathophysiological basis on these perception and feelings. And it also goes with neural reflexes such as baroreflex sensitivity. Where the baroreceptors are activated, it goes send the signals to the brain stem, especially nucleus tractus solitarius, which is the head of the parasympathetic nervous system. It's the nucleus. So when it is activated, it sends inhibitory inputs to these centers where pain, anxiety, blood pressure, and sleep are controlled. So pain, anxiety, blood pressure, those things are improved by activating the parasympathetic nervous system. This is the normal physiology. But what happens in chronic stress and emotional distress is the baroreceptors learn not to react because they are having overwhelming the stress inputs, and they learn not to react, and the baroreceptors and nuclear status volcaris activation is diminished. So they developed hypertension type pathologies and chronic pain. So chronic pain is not in the head, it always even though this is not supported by research, there are evidence that it has some pathological basis as well. And the other factor is the personality. The neuroticism-like personality, where proneness to distressing emotional states have been shown to influence perception of symptoms and well-being in rheumatoid arthritis in this study. And their self-sacrificing defense style personality, the pain was associated with impaired physical health related quality. So there is evidence, research-based evidence, that personality interferes with these psychosocial, the disease perception. And we know what's happening. Now we have to know how these behaviors are changed, not only perception. The pain is a very important safety mechanism. It is made for us to withdraw from anything threatening us, immediate threats. But sometimes this can be very harmful, because without a threat, even people might have pain. That's where you develop chronic pain-like syndromes. So this is something we can explain with behavioral learning. So some behaviors, the classic conditioning, operant conditioning, and social learning process. The classic conditioning, as you all know, the Pavlov's the well-known experiment with the dog, the involuntary action when there's a stimulus. But when the stimulus is removed also, he continued to salivate, and the involuntary reaction continued whenever the bell rang. So the same thing is like, for example, when patient sees a physiotherapist and with chronic pain, and she develops severe pain when she's undergoing physiotherapy, the next time, even without the physiotherapist trying to touch or do something, the patient might develop the sensation of pain. So there's something like that. And operant condition is voluntary reaction, and social learning processes learn behaviors from others. For example, children learn when the parents reward, they tend to do the same thing over and over again. And the negative side also same. So like this conditioning occurs in people. So their responses might vary according to these conditioning. So we have to understand and sometimes need deconditioning. The illness beliefs and cognitive factors, as in these studies, the one longitudinal study of patients with rheumatoid arthritis showed that illness perception and coping strategies contributed to fatigue and health outcomes. The effect of illness beliefs on disability and quality of life appeared to be relatively independent of disease activity. So the other behavioral thing is fear avoidance. Not doing something because of the fear of damaging or fear of doing harm, like patient with osteoarthritis not involving in physical activity, likewise. And self-efficacy is the patient's confidence in his or her ability to successfully accomplish a given task. So patient himself or herself thinks that this is not attainable. However much we try to convince that physical therapy is good or the exercise is good, patient baseline has a perception that this is not something that can be achieved. So this fear, avoidance, self-efficacy like things are negative factors affecting the patient's quality of life. A patient's self-efficacy to perform activities of daily living at the baseline is a significant predictor of disability, as I illustrated by a study which examined the disease activity over 12 months period in this study. And another thing very common in some of the patients is catastrophizing. So it is a combination of excessively focusing on pain sensations and the perception of not being able to cope with pain. Although the pain is there, already they have the perception that they can't cope with the pain, and the combination of both situation-specific pain-related and cognitive variables explain up to 60% of the variance in pain in this study of chronic back pain patients with rheumatoid arthritis. So catastrophizing is something sometimes very difficult to handle. Other thing is hypervigilance, where patients look out for symptoms very vigilantly, more than what is needed, especially in conditions like rheumatoid arthritis, where they know that there can be exacerbations and flare-ups, and they are anxious about that. And psychological flexibility and rigidity is something, the rigidity, especially patients, they don't like to, they eliminate such some things from their life even. They are that rigid that they eliminate hobbies and some part of their social well-being, and they expect 100% cure or 100% symptom-free by eliminating these factors, which is not possible. So this rigidity is seen in some of the patients. Health-related quality of life, it's an individual perception, and it has 4 components: physical, psychological, social, and symptoms of disease or the treatment. Why I'm talking about this is, if we only treat the symptoms of the disease or the treatment, the health-related quality of life won't be there. So that's why psychological, social, and other things also need to be considered in our patients to improve their health-related quality of life. Ultimately, that's what matters. And a lot of patients ask us whether we should rest, whether we should exercise, whether it's harmful. So traditionally, the rest is considered, but now it's well known that exercise is a better thing, but it should be recommended according to the individual patient. And it's important because it goes against sickness behavior, which can be a vicious cycle, and it improves fatigue and improve the mental health. So we should explain these things to our patients. And the social functioning, where we should ask about the roles, work-related things, and interpersonal relationships. Sometimes they may be suffering from these things. And when we are measuring the health-related quality of life, there are 4 tools that are commonly used by the rheumatologists. The first 2, the short form 36 and WHO quality of life tool is a general tool, which not only the rheumatologists use, but the other 2, arthritis impact measurement scales and health assessment questionnaire, they are mainly aimed at rheumatological conditions. So these are widely used in research purposes. The coping is an important strategy. It refers to cognitive, behavioral, and emotional process by which people attempt to limit the impact of stressors. So sometimes we can't eliminate the stressor, such as pain from a damaged joint, but the coping strategies should be taught or implemented by both the patient and the therapist. And coping strategies also vary according to the disease course, because the chronicity of our diseases. For an example, early rheumatoid arthritis patients try to cope with denial, telling that whatever we say that stopping the medication, or telling that I can't have a disease like this. If we say in the first go that you have a chronic disease which needs a long-term treatment, sometimes it might be too much for a patient to take. But the catastrophizing is also a coping strategy which is negative. What is advocated is active coping strategies as opposed to passive coping strategies. Passive means thinking that everything will be okay, hopeful, and one fine day I will be okay like. But active means doing something for your pain or something for your stressor. So active coping strategies are always encouraged, and expression of emotions is one good coping strategy that may lead to better psychological and physical adjustment, and it has been proven by research as well, not only in rheumatological conditions but a variety of chronic conditions. Other thing is social support, which is either structurally or functionally, not only structurally, functionally also we should assess, because functionally, how much of the social support the patient has does not depend on the number of people who are willing to support. It's the patient's willingness and the quality and the way they support the patient. So the functional one is the most important one, because however much the others support the patient, it's not what they would expect from the others. So functional social support is what we should assess. Treatment strategies for our patients include education, which is the cornerstone of the treatment of psychosocial problems, and prevention of these negative psychosocial impacts, and the exercise, because it's evidence-based. Especially for rheumatoid arthritis and fibromyalgia, there are a lot of data to promote exercise, and the impression that the doctor should cure everything, this is going out of the trend, and self-management strategies should be implemented and should be taught to the patient, which can be very difficult in some of our settings, but the patient should be made prominent in our treating strategies, making him or herself the main person around which the management strategies are reinforced. Otherwise, it won't be a successful thing when we treat especially these psychosocially affected patients. So self-management is one of the best things that is practiced in other countries, and the behavioral interventions commonly done by the psychotherapists, cognitive behavioral and occurrence behavioral therapies can be implemented as well. In daily rheumatology practice, what we can do, because not all our patients are, the symptoms are due to psychosocial problems, they do have a rheumatological condition. First, we should diagnose and treat it, and treat effectively and early. And meantime, we should identify the psychosocial factors and the long run their consequences. And continuous education, exercise, and cognitive behavioral treatments with appropriate treatment. Those are the things we can do in our practice, but there are limitations, because one thing, most of the perception from the patient side would be the tablets, and we have some resource problems as well. Mainly our busy clinic settings, it is very difficult to find time for individual patient, because these are sensitive issues. It will take time for patients to come up with these issues, and there are confidentiality issues, because we see a lot of patients in one clinic room, and it's not practical sometimes to talk these things. And the stigma. These assessment tools are very helpful, but they are difficult and time consuming. So mainly they are based in research purposes. And the lack of resources, as I told, both human and other. For example, lack of the support from social worker or psychotherapist or for these non-pharmacological management. So it's mainly pharmacological management we are doing at the moment, although we do support these areas time to time. What can we do about these things is first we have to improve not only the patient education but the education of the medical professional, and it should be continuous, and there should be a continuous assessment of the patient with supporting the psychological area. Be empathetic with the patient, because some of the patients they might be having these issues which with non-compliance. They may have these psychosocial issues which should be addressed, and always consider non-pharmacological interventions along with pharmacological intervention. That's what we can do. So the quiz for you is Mrs. D, a 26-year-old systemic lupus erythematosus patient who has a moderate disease activity with 4 flare-ups per year. She feels very nervous, depressed, and has severe sleep disturbances. Her most debilitating symptom is fatigue, severe fatigue, with steadily increasing fatigue through the morning hours. So, although I didn't talk about fatigue much, I thought I would put this question and as a general question. So, to make awareness of these common symptoms on our patients, always going to different doctors, telling that vague symptoms. So, physical activity patterns. Which statements are correct? A, physical activity patterns have little impact on fatigue. B, younger women with SLE and Sjogren's do not seem to be particularly vulnerable to the negative impacts of fatigue, regardless of their social situation. I told you these are very easy because it's from the common sense rather than the lecture. And fatigue is common in SLE and Sjogren's, but uncommon among patients with rheumatoid arthritis and ankylosing spondylitis. D, fatigue is only increased when SLE patients display an increase of their disease activity. So, E, fatigue is most often associated with pain and depression, whereas evidence that diseases, activity, and medication usage are predictors for fatigue are inconclusive. So the E is a long sentence, but it's easy. The answer is easy. So what will you say? A. What is the answer? Is it correct? Yes, it's correct. The physical activity patterns have, it's wrong. Physical activity patterns have a clear indication, improvement with fatigue. There are clear indications that medium physical activity patterns impact fatigue, and that therapies employing graded physical exercises may improve fatigue. So it's one of the things recommended in fibromyalgia, where fatigue is very common. Graded physiotherapy, where we say start low and go slow. And B, sorry, I put the answer. Okay, you know that younger patients with SLE and Sjogren's, they have more negative impact because of their multiple social roles, because they are like mostly having young children. They should be active all day, but they are the ones most commonly affected with fatigue. So it's always more in these ones. So this should be acknowledged. Sorry, so what is the answer for third one? I have to go back. fatigue is common. Fatigue is common in SLE and Sjogren's, but not common in rheumatoid and ankylosing spondylitis. Because it's equally common, where 40 to 60% in SLE and Sjogren's and rheumatoid ankylosing spondylitis, and 80% in fibromyalgia. Fatigue is only increased when SLE patients display an increase of disease activity. That is also very easy. Although there are several studies showing strong association between fatigue and catastrophizing, psychological pain therapy, fatigue is only increased SLE. I think I have put the wrong answer here. It's not very conclusively shown to be associated with inflammatory process. So there's no linear correlation between those two. And the last one is fatigue is most often associated with pain and depression, whereas the evidence that disease activity and medication usage are predictors of fatigue are inconclusive. So it's the same thing, more or less. So it's associated with pain and depression, and to less degree, minimally with inflammatory disease. So there's no known medication for fatigue. Aiming at fatigue, although there are several biologists who claim that they will cure fatigue, but there are no conclusive studies on that. The pharmaceutical companies, they aim this thing very much because it's so common in patients, although the disease activity is controlled with biologics, the quality of life will not be improved because of the fatigue. So the newest aim is the cytokines and things in fatigue, which is still very inconclusive. So that's it. Thank you for listening for your time.